Greetings. This is Dr. Karl Golnik coming to you from the University of Cincinnati in Cincinnati, Ohio, United States. Happy New Year to everyone. This is my first webinar of the year, and we decided on a topic, neuroimaging for the ophthalmologist. So I'm hoping to show you lots and lots of neuroimages and try to cover some of the more common things that we see in ophthalmology, at least from a neuroimaging standpoint. One of our fathers of neuro-ophthalmology in the United States is Bill Hoyt, and Bill Hoyt said this about neuro-ophthalmology. Neuro-ophthalmology is that subspecialty where the diagnosis is made upon reinterpretation of allegedly normal scans. And so I think this is certainly true, and I routinely look at MRIs or CT scans where they were read as normal and actually are not normal. And I will show you some number of examples of that as we go through the webinar today. So my objectives are, we'll be able to describe, when we're done, you will be able to describe what type of neuroimaging to order. You'll be able to list some of the pitfalls. Pitfalls mean some of the difficulties, I guess, in imaging interpretation, and that you'll be able to recognize MRI and CT findings of common neuro-ophthalmology problems. So in the way of an outline, I'm going to talk just briefly about CAT scan versus MRI. Then we'll talk about some of the pitfalls, some of the difficulties and problems that can be encountered when you're ordering these tests. And then we'll look just at a whole sort of a potpourri of common neuro-ophthalmology conditions and how the imaging will look. So I'm going to start just with a polling question here, and this is something that I will read the question, and the question is, MRI is preferable to CT in all of the following except which of these four conditions? So is it preferable in brainstem lesion? How about a patient with a bitemporal hemianopsia? Or how about a patient with thyroid eye disease or acute stroke? So the question is, which one of these is MRI not preferable? Is MRI and CT maybe similarly useful? And you can vote by clicking on your computers for one of these four things. I think you simply click in the circle next to the poll. And I'm not sure you're seeing that poll, honestly. Oh, yes, you are. So here's the responses. So we have a couple people thought maybe a brainstem lesion. A couple of people said bitemporal hemianopsia. So certainly in bitemporal hemianopsia, we're thinking about a chiasmal region problem. And MRI is definitely better for the brainstem. It's definitely better for the chiasmal, the cella, and suprasellar region. And then actually the majority of people, about half, thought acute stroke and the rest said thyroid eye disease. And the answer is thyroid eye disease. So acute stroke, as I'll show you, I think, in other words, acute, depending on how you define that, but certainly if you define it within the first 24 to even 36 hours, a CAT scan may not show any abnormalities in the first 36 hours in somebody with an ischemic stroke. So a typical ischemic stroke, CAT scan can look normal, and I think we'll show an example of that as we go through the webinar. So an MRI is definitely preferable in acute stroke. Now, hemorrhage, if there's a hemorrhage in the brain, that's another story, and either an MRI or a CT would show that. But certainly if there's a hemorrhagic stroke, and that's why they might quickly, at least in the United States, if you go in and they think you've had a stroke, they want to rule out bleeding in the brain because that can kill you quickly, whereas an ischemic stroke probably won't. So they often will do a quick CAT scan to rule out blood. So CAT scans are good for blood, but if it's ischemic and there's no blood, then the CAT scan can look totally normal, and we'll get to that in a moment. But thyroid eye disease, which is, of course, an orbital process, and most orbital processes, a CAT scan is probably just as good as an MRI. And depending on where you live, a CAT scan may be cheaper and it may be easier to get than an MRI. And we'll go over some of the pros and cons of that in a moment. So what about CT versus MRI? Well, of course, there may be patient factors that dictate your choice. So if there is any magnetic metal, these days, at least in the US, they use titanium and have been using titanium, which is not magnetic. That said, metal, non-magnetic metal, can certainly cause artifacts, both with CAT scan and with MRI. I just saw a patient recently who was thought to have an inferior rectus muscle problem because of an MRI that was done for double vision. And she had extensive dental work, and there was a metallic artifact. And when we got a CAT scan, although there was metallic artifact, it looked different. You could tell that the inferior rectus muscle was actually totally normal on the CT scan, whereas it looked abnormal on the MRI because of the metallic artifact. So the metal, again, if it's magnetic, you can't get an MRI. And if it's non-magnetic, you can, but the CT and the MRI both have different types of artifacts with metal. Magnetic metal is perfectly okay, of course, for the CT scan. And then sometimes patients have claustrophobia, they have trouble with tight spaces, and they are not going to appreciate the MRI. So when I talk to patients about the MRI, I ask them if they're claustrophobic. If they say, yes, I'm claustrophobic, usually that means they can't do the MRI, certainly not without some significant sedation. I try to avoid, intravenous sedation. I do prescribe Valium, I'm blanking on the generic name, but I might prescribe some sort of an anti-anxiety agent if they have mild claustrophobia. Certainly some people don't think they're claustrophobic, and they get in the MRI machine and they realize they are claustrophobic. And then MRI, as I say here, it's better for pretty much anything in the brain or in the skull base. So if you're looking, if you're thinking brainstem, if you're thinking brain, almost always the MRI is better. Now, the exception to that would be if you're interested in the bone. So in the orbit, I think the MRI and CT are fairly equivalent. But if you're specifically interested in bone, why would you be? Well, maybe there's an abnormality that you see on the MRI, and you want to know whether the bone is being involved, because oftentimes bad things like metastases may erode the bone. That's very difficult, or not very difficult, impossible to see on MRI. As we'll see in subsequent slides, the bone is invisible, if you will, to the MRI. So the CT, I think, is as good as MRI in the eye socket. If you're sure it's a condition of the eye socket, then CT is probably better. If there's exophthalmos, with certain exceptions, then perhaps the CT is just as good. And if you're looking at bone, then the CT, of course, is far superior. There's also some talk these days about MRA versus CTA. So as you probably know, the MRA, magnetic resonance angiography, versus computed tomographic angiography are both ways to look at the blood vessels. These are both simply software variations on the MRI and CT machines. It does not require anything extra, really. You just push some different buttons to get the MRA and CTA. And depending on your institution, some institutions just do really good MRAs, some do really good CTAs. So it doesn't really matter too much, I think, between MRA and CTA. If you know where you're getting your neuroimaging, you can often ask, which is better for, oftentimes we're thinking about aneurysms, sometimes cavernous sinus fistulas. But if you don't know, you can always ask your radiologist, hey, where we are, which is better for detecting aneurysms? Is it our MRA or is it our CTA? And we'll look at some examples of those momentarily. I would note that I didn't mention earlier on, but if there are questions as we go through this, we're going to answer questions at the end. So you can type in your questions at any time, but they won't be answered until we stop at the end, and then I'll try to answer all and any questions that come up. So when do I order what? So for MRI of the head, if the person's chief complaint is double vision, they have ocular misalignment. Of course, it's binocular double vision, but if they have misalignment of the eyes, I want the MRI of the head. Could it be an orbital process? Sure, but it could definitely be a brain process, so the MRI is going to be better for double vision. If the person has a bilateral optic neuropathy, and I'm worried about something in the sellar region or intracranially, then I'm going to order MRI of the head. If there's a retrochiasmal visual field defect, of course, that's brain, MRI of the head. Any suspected intracranial pathology, MRI is superior. Now, you may not have MRI, so I'm just talking about what I'm going to order if I have the choice of both. Obviously, if you don't have MRI, CT is going to be the next best mode. How about MRI of the orbits? Well, if there's a unilateral optic neuropathy, I often order an MRI of the orbit. Why? Because if it's unilateral and it's compressive, then the lesion is going to be in the orbit, typically, and I'm going to get really good views of the eye socket if I order MRI of the orbit. And I will get automatically in the US, if you order MRI of the orbit, we'll get fat suppressed views. And I'll show you what that means in a moment. So if there's a unilateral optic neuropathy, I order MRI of the orbit. If there's a bilateral optic neuropathy, I order MRI of the head. Now, sometimes in the United States, a unilateral optic neuropathy in a young person is going to be optic neuritis, and we're interested in plaques for demyelination in the brain. But if you order an MRI of the orbit, you'll get brain. In other words, they can't do the orbits without getting your brain. They just won't get detailed views, but they'll get good enough views to look for plaques in the brain. So instead of ordering orbit and head, I just order orbit. Why? In part because in the US, if you order orbit and head, that is 2 studies. And 2 studies cost twice as much as 1 study. And in the US, we're talking about literally thousands of dollars. How about CT of the head? Well, if you really need something fast and you're worried about bleeding, as I mentioned, blood in the brain will show up well on a CAT scan of the head. If you're only concerned about hydrocephalus, then a CT will clearly show you enlarged ventricles. That's rare that you're only concerned about hydrocephalus, but that's when a CT of the head might be ordered. CT of the orbits, I routinely order a CT of the orbits in somebody with Graves' disease or thyroid eye disease. If I'm quite certain that it's an orbital process, there's unilateral exophthalmos, extraocular motility problems, I'm not considering a cavernous sinus fistula, which would be different imaging, then a CT of the orbit may well be good enough. Now that said, I've had patients where I find a problem on a CT of the orbit and they say, would order MRI to correlate. But I've also had the opposite occur. So the MRI shows an orbital lesion and the report says correlate with a CAT scan to look at the bone. And then CTA versus MRA, as I mentioned, I think that depends on your institution. They can both be excellent ways to look at the blood vessels, to rule out aneurysms, to look for cavernous sinus fistula and arteriovenous malformations. So that's sort of my general philosophy about CT versus MRI. I want to move on to sort of the second part of the webinar, which is pitfalls. And here are the pitfalls I'm going to consider. Wrong study, no contrast given, no fat suppression, no instructions, and no persistence. And I'll run through each of these briefly. So here's a case of the wrong study. This is a 60-year-old man. He awoke today with blurry vision, and he was off balance. He had a history of diabetes and high blood pressure. On examination, and I saw him actually after he went to the emergency room, he had a right homonymous hemianopsia. And here is his CAT scan that was done in the emergency room. We're down a little bit lower here looking at his cerebellum. He was off balance, as you'll remember, but this is a CT scan. They sent him from the emergency room to see me because of his visual complaints. And here's his CT scan, which looks pretty normal. But let's look at an MRI cut the same day, looking exactly the same place. And you'll see he has multiple, and hopefully you can see my pointer, he has multiple strokes. These are ischemic strokes. This is not blood. And so that's why I say in MRI, within the first 24, maybe 36, a CT within the first 24 to 36 hours may look totally normal. And so I sent him back to the emergency room and said he needs an MRI because he had a homonymous hemianopsia. And further up in his brain, in the occipital lobe, there was a stroke that was causing him his homonymous hemianopsia, and they admitted him actually for treatment of an acute ischemic stroke. So stroke may not show on the CT, certainly within the first 24 hours. I fairly routinely see people, I think the most common is the person has an occipital stroke. They have only visual symptoms. They go to the emergency room, CT scan is normal. Oftentimes I see them, days or even weeks later. I tell them, gee, you have a homonymous hemianopsia, you have diabetes, high blood pressure, you're 65 years old, you probably had a stroke. And they said, oh no, I didn't have a stroke. They did a scan when I went to the emergency room that showed no stroke. So MRI better than CT, except in orbit or bone. And this is another polling question. And this is just to help me understand a little bit what you all, the audience, has available to you. So the question is, what is your access to neuroimaging? Can you, and read these, don't answer right away, can you get an MRI the same day if needed? If not, can you get one within a week? If not, can you get one within a month? Or can you only, D, can you only get a CT? Or E, neither available, which would obviously be a big problem. So that's the question. I'm curious. I think I've covered most of the bases, but so MRI same day if needed, so get it really quick, or within a week, or within a month, or only CT, can't get an MRI within a month. And here's the results. Now, I'm not sure they can see those results because they're not on my main screen, but the results are 19%, about 20% of people can get the MRI the same day if needed. 50% can get an MRI within 1 week, 15% within 1 month, 13% CT only. So the majority of people, really, 70% of you can get an MRI within 1 week. That's pretty good, I think, pretty good. Okay, that helps me a little bit. So here's another case of what I thought of was the wrong study. So this is a 70-year-old woman who had a droopy lid for 1 day. She had a discharge for a deep venous thrombosis, and her MRI was said to be normal. She did have a past medical history of melanoma that had been excised from her skin. And on exam, the reason I was seeing her other than the ptosis was that she had a 5-prism diopter right hypertropia when she looked downward. And she had slight proptosis and then, of course, the obvious ptosis. So she has what sounds like maybe an orbital process, maybe not. This could be maybe a mild third nerve palsy or something like that. So her MRI was done, and they ordered an MRI of her brain. And here's one of the cuts of the MRI of the brain. And they interpreted and said, well, everything looks okay. Here's another cut of the MRI of the brain, some more cuts, MRI of the brain, and here's ultimately the study that we ordered, which was the MRI of the orbit. And what you'll see here is in her right orbit, you'll notice here's the left superior rectus, and hopefully you can see my pointer okay. Here's the left superior rectus levator complex, and here's the right. And what you'll notice here is that this superior levator complex is much enlarged compared to the left. So this can be fairly difficult to see on an MRI of the brain because you may not get good views of the orbit, and you may not get, depending, good coronal images of the orbit. So in this person who has mild proptosis and double vision with ocular motility problems, clearly you're going to want to look at the orbits as well as the brain, and you're going to look for things that may be somewhat subtle. So this person actually had, I believe this was a metastasis, melanoma metastasis to her orbit. And here you can see again on the sagittal view of the orbit, here is that lesion right up above the superior rectus levator complex and involving it. So here's the lesion in the orbit. So you need to give good instructions and order the correct test of the correct anatomy. And that simply means, don't keep it a secret. If the person has double vision, tell the radiologist, what are you looking for specifically? In this case, we said, listen, the person has exophthalmos and double vision. We strongly suspect an orbital lesion. So give them as much information as you can give them to help them as they get the study. And I know there are some places where really the radiologist determines what study is ordered. That is problematic, I think. And I think it's much better if you, the ophthalmologist, knows enough to order the right study, because usually, clearly, at least from a neuro-ophthalmology standpoint, I'm definitely going to know way more than the radiologist about the best study to order for the problems that I am seeing on my exam. So order the right study. Here's the second pitfall, the second problem. No contrast. So gadolinium, gadopentate, I'm not sure what it might be called, but no contrast, or an iodine-based contrast in CAT scans. So this is a 40-year-old woman, gradual loss of vision in the left eye, painless loss of vision. She's 20/20 or 6/6 in the right eye, 20/60 or 6/18 in the left eye. There is a left relative afferent pupillary defect, and she does not see any of the color test plates with the left eye. So we know that this woman has a left optic neuropathy, a unilateral optic neuropathy. And I mentioned earlier that if I see someone with a unilateral optic neuropathy, I'm going to order an MRI of the orbit. So here's the non-contrast MRI of the orbit, and you can see here, in this case, here's her right optic nerve, here's her left optic nerve, here's the white here is the orbital fat. We're in sort of in the back of the eye socket where the muscles and the annulus of Zinn are sort of coming in. And there's nothing really obvious, I don't think, in this scan. I mean, there's a little asymmetry between the nerves, but, you know, it looks like maybe this black is of the nerve sheath. Maybe there's a little fluid around the nerve sheath. Nothing too obvious in this non-contrast scan. But here is the gadolinium enhanced scan. And what we see here, here's the right optic nerve right here. No enhancement. Look at the left optic nerve. There is marked enhancement all around the optic nerve. This person has a left optic nerve sheath meningioma. And this meningioma can be very difficult to diagnose. It's near impossible to diagnose unless you give contrast. In this case, in the MRI, gadolinium. So if optic neuropathy is present, I always get it with contrast. There are very few times that I order an MRI where I don't ask for contrast. Very rare that I would ever do that. So order the gadolinium almost every time. Here's another pitfall, another problem. No fat suppression. Here's the 30-year-old. I saw this person fairly recently. Another Caucasian woman, gradual loss of vision in the left eye. She's 20/20 or 6/6 in the right eye. 6, I don't know what that is, 24, thereabouts, in the left eye. Doesn't see any of the color plates. Definite left relative afferent pupillary defect. Kind of non-specific looking visual field test, generally depressed. Here are some images. So here's an MRI of the orbits with no gadolinium and no fat suppression. So this is all fat in between the muscle and the nerve, right? All this orbital fat is bright white. This is a T1 image. We'll talk a little bit more about that. The T1 we know because the vitreous, the fluid is black. And so here's the same MRI in a patient with gadolinium, but there's no fat suppression. So you still see all this very bright white fat. It doesn't look significantly different than this. The one difference is there is some enhancement of the extraocular muscles. That's normal. The extraocular muscles will enhance when you give gadolinium, but you don't see any obvious lesion here. Here is the MRI, same patient, MRI with gadolinium and with fat suppression. So now the fat, and this is just a software sequence, the fat is gone. It's black because of this fat suppression computer program sequence. And now look back here at the back of the eye socket, whereas this used to blend in, this enhancement blended in some with the orbital fat, now it's much more obvious that there is an abnormality. And in this axial MRI image, we've cut right through the nerve, and this is another optic nerve sheath meningioma. So there's meningioma that wraps around the nerve. We're cutting right through the nerve. And so all we're seeing is the enhancement on either side of the nerve of this nerve sheath meningioma. So one of the other reasons I order when I see a unilateral optic neuropathy, and I'm considering that there could be something in the orbit, I automatically get fat suppression. In the US, if I order orbit, I get fat suppression. Why? Because there's fat in the orbit. If I order brain, I don't get fat suppression. Why? Because unless you're a fathead, there's no fat in your brain, and you don't need to do fat suppression. So that's why one of the reasons I order orbits, I automatically get fat suppression. If you don't automatically get fat suppression, when you order an orbital MRI, then you need to write it out. And when MRIs were becoming more popular in the US years ago, I had to write it out on every time I ordered it, orbital MRI with fat suppression and with gadolinium. Here's a patient with bad instructions. So here's a 59-year-old guy. He has double vision for the last 6 weeks. He has high blood pressure. On exam, he has a subtle right sixth nerve palsy. Look at how well his left eye abducts compared to his right eye. And he has an esotropia. He also happened to have a fifth and seventh nerve palsy. That's a different lecture, but we always check. It says to turn off the video, I think. Hold on. We always check facial sensation and facial nerve function, motor function, when we see a sixth nerve palsy, because the differential diagnosis is much different for if there's a 5, 6, and 7 versus just a 6. So suffice it to say, he had mild right sensory problems on the right, mild right seventh nerve findings, and a mild right abduction deficit. So we sent him for MRI of the brain because he's got 5, 6, and 7. We're thinking about brain stem area. MRI is going to be much better than CT. And sure enough, they called me. I think this was 1 or 2 days later and said, yep, we found the problem. This guy, and it's hard to see on the scan, but I'm trying to point it out there. We found this small left pontine lacunar infarct in this hypertensive 60-year-old guy. There's your answer. And I said, wait a minute, I'm pretty sure he had a right fifth, sixth, and seventh nerve palsy. And they said, oh, well, this is where the problem is. And I said, show me the films. And they sent me the films, and I said, what's this? And it turned out to be a metastatic lung cancer lesion, not in the brain stem, but in the cerebellopontine angle, where 5, 6, and 7 run. So this was the first sign that he had lung cancer. He had an unknown primary when this was done. It looked metastatic, and we got I think at that point he just had a chest X-ray showing obvious lung cancer. So make sure you give good instructions. I tried to give this person good instructions, but they didn't follow it very well. Because they found that little left-sided abnormality, they really didn't focus on the rest of the picture, which seems in hindsight very obvious. There's an enhancing lesion where I have this yellow arrow and not a good-looking one. So give detailed instructions, try to avoid this problem. It didn't really help me much in this case, but no secrets, right? Tell them exactly where you think it is. And I oftentimes have radiologists say, gosh, you knew exactly where the problem was. That's right, that's what neuro-ophthalmology is all about. Okay, here's another no instructions. This is a young woman, double vision. When she looks to the left, she has hyperthyroidism. A scan was done because she had double vision. I think before I ordered it, someone else ordered a CAT scan and said double vision. And an MRI, I guess, although I think I'm going to show you a CAT scan. And the scan was read as normal, but she developed a little esotropia when she looked to the left. Here's her CAT scan. How do we know it's a CAT scan? Well, because all this white stuff is bone, right? So on MRI, this is all normal. Or not normal, invisible, it's black. On a CAT scan, it's white. That's why when we say if we want to look at bone, we need to do a CAT scan. So the extraocular muscles are often misread or overlooked by radiologists. I've even had people where I said, I am interested in this particular muscle, and the scan report comes back normal. And here's this patient who had mild thyroid eye disease and an enlarged left inferior rectus muscle. So when she was looking to the left, This tethered the eye a little bit. And remember, in thyroid eye disease, it's not a paralytic process, it's a restrictive process. So she had an enlarged medial rectus muscle consistent with thyroid eye disease. If we go back for a moment to look at her, you'll notice she's got a little eyelid retraction on the right. So as soon as we see a little eyelid retraction on the right and a large muscle on the left, it tells us it's bilateral, and it tells us that this is thyroid eye disease. And then the fifth problem, the fifth difficulty, or what I call pitfall, is no persistence. So this is a young guy who complains of vision loss in the right eye for 3 months. He does have an important past medical history, Ewing's sarcoma of the femur, treated some years ago, and he was thought to be disease-free. He had, on examination, he had a right optic neuropathy, and of course, because of the vision problem, before he saw me, he saw his family doctor who said, "Oh, you had cancer, we're going to get an MRI," and he saw his oncologist who's the same week who said, "Oh, we're going to get an MRI." They both ordered MRIs. Both MRIs were said to be normal. Even though, and why he had 2 MRIs in a week without saying something, I don't know, but he was a good patient, I guess, and was compliant. They thought, you must have optic neuritis. You're a young, healthy guy, other than this old history of the sarcoma, so it must be optic neuritis. So he was then ultimately, after some months, sent to me. And here's the score, so the scoop. So in October of 2002, his vision was 6/12 or 20/40 in the eye. About a month later, 5 weeks later, in early November, he was 6, whatever that equals, 24 or 20/80. And by the time I saw him, another month later, he's count fingers. So the first question is this the history of optic neuritis? And the answer is clearly not. Optic neuritis typically will occur fairly acutely, and hopefully within 1 or 2 weeks, the vision will be at its worst. And over the next few months, the vision will do the opposite of what we've seen here, and that is the vision will gradually improve. So clearly, this is not the story of optic neuritis. So I said, of course, what all good neuro-ophthalmologists say is, show me the films, show me the MRI that you had done. And here's the MRI, a little washed out. So again, we're looking at the right optic nerve. You can see that this is an MRI. There's the bright orbital fat, right? So this is a non-suppressed image. There was no gadolinium or fat suppression. Of course, what did we recommend? Although I thought I saw the abnormality, look right here. There's something a little asymmetric in the optic canal. But when we give gadolinium and we do fat suppression, you now see the fat. You probably didn't need fat suppression for this, but the fat is gone like we would expect. And here with the gadolinium, the muscles enhance, like we said, and this lesion, which turned out to be a Ewing sarcoma metastasis, ultimately the patient died of this, was causing a compressive optic neuropathy, and there was no persistence. So they thought, oh, must be optic neuritis, but he got worse. Clearly that led us to say, let's look at the scans. I think you can make a diagnosis over here, but you definitely want to give gadolinium and do fat suppression in setting of unilateral optic neuropathy. And here are a bunch of other scans. All of these scans were read as normal by the radiologist. And clearly you all probably have very different levels of expertise in terms of radiology. I was in a country recently where they had an MRI and they had no radiologist, which really puts the onus on the ophthalmologist. But this patient had a right optic neuropathy, and this MRI was read as normal, even though it was done with gadolinium. See the muscles enhancing? Here's enhancement in the optic nerve into the chiasm. So this was read as normal. Another patient, here's the right optic nerve as it's forming the optic chiasm. Here's the left. Here's the pituitary gland, which also enhances. So if you see a nice bright white pituitary, that means gadolinium was given here. This is the suprasellar area right up here. And here's the enhancing distal nerve, read as normal. Over here, hopefully everyone sees the problem. This was read as normal, even though I said rule out abnormality of the right inferior rectus muscle. Look at the right inferior rectus muscle compared to the left inferior rectus muscle. Thyroid eye disease. And here's a patient with double vision, known I think this was colon cancer, thought not to be metastasized with this giant, in my opinion, orbital lesion, actually a metastasis. Here's the superior oblique muscle right here. Here's the met to the superior oblique muscle. Here's the normal medial rectus right down here. But this was a metastasis to the superior oblique muscle causing the double vision. I showed the patient the scan and he said, "What's that?" And I said, "Yeah, that's the normal scan." He was not happy. So that's another, all of these scans are reasons that you, the ophthalmologist, should be looking at your scans because you know exactly where you want to look. So the top 5 pitfalls are, or the solution are, get the right study, give contrast to everybody, get fat suppression. If you're interested in the orbits, get fat suppression. Give specific instructions and be persistent. All right, now I'm going to talk a little bit just about some imaging differences. And so here, this is a third polling question. And you can see the MRI here, and it might look familiar because I just showed it. The MR image below is which of the following? Is it a T2 weighted image? Is it a T1 weighted image? Is it T1 with fat suppression? Or is it T1 with fat contrast, and with fat suppression? So let's see if you were listening. I'll give you a second to vote for these. So T2 weighted, T1 with fat suppression, T1 with contrast and fat suppression. And the results are, okay, nobody said T2, very good. Only a couple people said T1. It is T1, and then a third of you said T1 with fat suppression. It's definitely with fat suppression, but it's also with contrast. And so what you'll see here is the fat suppression, that it's T1 because you can look at the globe. If it's T2, it's going to be white. The vitreous will be white. T1, it will be dark, so it's T1. There's definitely fat suppression because all this is fat in the orbit. And if there's no fat suppression, this is going to be bright white. And it's also with contrast. Look at the extraocular muscles. So the only 2 muscles we're seeing are the medial and lateral rectus, both enhancing. This was a scan where I showed you there was a little enhancement right here, but you can look at the muscles and say, aha, it's with fat suppression. So this is a T1. The vitreous is dark. With fat suppression, the fat is not bright white, and in contrast, the muscles are enhancing. So T1, T2, here's a T1 in the upper left, yes, a T1 in the upper left, no fat suppression. There's a nice bright white fat. The muscles are not enhancing, so this is a T1. T2, look at that bright white vitreous. So the vitreous will be bright white. The cerebrospinal fluid, see down here, is bright white. So the fluid around the optic nerve, the normal fluid in the optic nerve sheath, bright white. This is T2. T1 with fat suppression, the fat signal goes away. The vitreous is dark, the spinal fluid is dark, the muscles are not enhancing. T1 with fat suppression, in contrast, the muscles are enhancing, the pituitary down in here is enhancing, and that's how you tell the difference. CT versus MRI in bone. As we said, here's the CAT scan. It's obvious. You see the nice thick bone, normal looking bone, the very thin lamina propria, right? That's why they call it that. It's thin as paper, so it's hard to see on a CT. But here's the normal bone on an MRI. It's invisible. It's black. So that's why I said, if you want to look at bony detail, you get a CT. Let's see. I think just some things to point out. Just normal and fairly normal anatomy. Hopefully everyone can identify the extraocular muscles, the optic nerve. This image is a CT scan. You see the nice white bone. What's this? This is image, the person is just rotated slightly. So this is the back of the globe. So this is not a tumor. You'll notice that when you look, of course, at other images. It's just the back of the eyeball because the image is the patient's head is slightly rotated. Here we have a coronal image further back. Here's the optic chiasm. Here's internal carotid artery here. Here's the suprasellar area. In this case, this would be a partially empty sella, if you hear that term. It means that the pituitary gland is kind of squished down here. You can see a partially empty sella. as an increased intracranial pressure, but you can definitely see a partially empty cella as a totally normal finding, totally normal. And here's a nice sagittal image through the midline with the cerebellum, the pons here, medulla, midbrain. Here's the cella, partially empty. The pituitary gland is being squished down here. Here's the optic nerve and chiasm right here. This structure right up here is the superior ophthalmic vein. We'll be looking again at that in a little bit. So let's look at some common neuro-ophthalmology conditions that you will see. Graves' disease, we've seen this already. This is certainly probably the most common orbital condition you're going to see. You'll see these nice, very enlarged muscles. This is a contrast enhanced CAT scan. So you see the white bone, you see the white muscles for the contrast. You see why a compressive optic neuropathy may occur, because back in the back of the orbital apex, you've got bone here and here. You've got muscles that are big. You've got nerve. The nerve loses that battle because the bone isn't going anywhere. Of course, you can do an orbital decompression to remove bone and give that nerve breathing space so you can get rid of the optic neuropathy. Here's a patient, of course, with the orbits. We like to really look at the muscles. You need a coronal image. So this is another CAT scan. You see the bone, and you see the big muscles for reasons that are unclear to me. Inferior, most common, medial second, superior and lateral. A good example of symmetric looking thyroid eye disease with some of the extraocular muscles enlarged. So inflammatory, type of inflammatory condition. Here's a patient you, depending on where you live, may not see much central nervous system sarcoidosis, but you get this nodular, lumpy, bumpy looking enhancement of the meninges. All of this is abnormal inflammation. Here we are further back where you see this, just this enhancing inflammation in a patient with neuro-sarcoid. So that's what meningeal enhancement may look like. In this case, in sarcoid, it's often nodular looking as opposed to smooth that you may see with other conditions. Optic neuritis, we've talked about a little bit already, that certainly most patients, not all patients, most patients with optic neuritis will have enhancement of the optic nerve, which is apparent. Again, this is a T1, fat suppressed, contrast given, look at the muscles, normal nerve on the left, not enhancing, enhancing nerve on the right in optic neuritis. Sometimes I'll get a report back that says, not optic neuritis, the nerve doesn't enhance. The nerve does not always enhance in optic neuritis. That does not rule out a diagnosis of optic neuritis. Here's what also we're looking for on an MRI. A T1, the fluid in the ventricles is white, but look at all of the plaques. This is a contrast enhanced. Look at all the plaques that we see in a patient with multiple sclerosis. So let's look at some tumors. And I'm going to ask a question. This patient probably has which of the following? So I will say before I give you the choices, this is a coronal image looking through the chiasmal area. This is a sagittal image. So here's the brainstem, cellular area. What do you think this patient probably has? Is it double vision? Is it a bitemporal field defect? Is it a headache? Or is it nystagmus? I'll give you a few seconds to vote. This one I think is an easy one. We'll see. And the answer is, okay, so about 87% of you said bitemporal field defect. Very good. No one said headache or nystagmus, and the rest 7 people said double vision. So we can get rid of that polling. And it's possible this person has double vision. Now, what we see in both cases are tumors. This is 2 different people. This is a craniopharyngioma. You can see a large cellular and supracellular lesion. There's a cyst in it, so that's a common characteristic of craniopharyngioma versus pituitary tumors. Here's the chiasm. So you can see it's pushing up and indenting. So clearly bitemporal field defect. Now, sometimes these tumors can get into the cavernous sinus on either side. Here are the internal carotid artery flow voids as you cut through the cavernous sinus. Here it is on length. This is internal carotid artery. But you can see tumor in the cavernous sinuses. Interestingly, even when there's tumor in the cavernous sinuses in the setting of craniopharyngioma or pituitary tumor. You don't usually get double vision. And then here's another patient, a sagittal image with this cystic lesion pushing up on the visual system. So most of you got the correct answer. Here's some other tumors we might see in the eye socket. This is a cavernous hemangioma in a very old CAT scan bone. So obviously a CT scan pushing the optic nerve to the side. Here's a small cavernous hemangioma causing no symptoms whatsoever. This was incidentally discovered. A non-fat suppressed image, right? So here's the fat. In this case, it does outline this benign tumor, the most common tumor we see in the adult orbit, a cavernous hemangioma. This is a patient we followed and did nothing and just observed them to make sure it wasn't getting bigger. And here is a patient with an optic nerve glioma, CAT scan, an old image. You can't separate this tumor from the optic nerve. So an optic nerve glioma. Here's a patient with another pituitary tumor. Here's the pituitary fossa. Here's the suprasellar region. Here's the chiasm draped over the top of this pituitary adenoma, the most common tumor you'll find in this general area. Here's another sagittal image, same patient with this large tumor. This is a non-contrast image, so there's no enhancement in there. Here's a patient who had a bilateral optic neuropathy. You can see both optic nerves heading into this large skull base meningioma, causing bilateral optic neuropathy. Here's the same patient with this olfactory groove meningioma that's just huge. This person actually did quite well when this tumor was removed with good recovery of vision. And here's a smaller pituitary tumor coming right up and just hitting the distal left optic nerve. This patient presented with a unilateral optic neuropathy, but had a tumor that was just coming up. Here's the right optic side of the optic chiasm and distal nerve. It was just the way it was growing gave us a left optic neuropathy. So pituitary tumors can do that. Here's another patient with a large sphenoid wing meningioma, or no, I'm sorry, this was a tuberculum sellae meningioma, brightly enhancing, and a sphenoid wing meningioma causing multiple cranial nerve palsies. This is a small clinoidal meningioma. Again, these will be the same intensity as brain unless you give gadolinium. They can be invisible without the gadolinium. If they're huge, you're going to see it. If they're smaller, you might not. So, and then another big olfactory groove meningioma causing, as you might imagine, a bilateral optic neuropathy as the nerves come back into the skull. And then an incidental finding in a patient, a meningioma that was growing in and causing pressure and really causing no visual symptoms, probably because it was extremely slowly growing. And then tumors in another nerve sheath meningioma. Here's the optic nerve. Here's a sagittal image with the tumor above and below, fat suppressed, gadolinium enhanced, and the same tumor on an axial cut. You can see the nerve kind of trying to run through the middle of it here. And then I showed this earlier, this very subtle tram track type appearance of a small apical, orbital apical and optic canal meningioma. And the same tumor here, we saw this early on when we looked at pearls and pitfalls. Here's a patient CT scan with a tumor right here that's involving the inferior and medial rectus. But importantly, and the reason why the CAT scan might be superior in some cases is look at the bone here. It's gone. This is a breast cancer metastasis that's eaten through the bone, telling us this is a bad problem, not a benign problem. This is a patient with both eye sockets filled with breast cancer. Just filled, chock, all of this enhancement is lung cancer. And then some intrinsic tumors. So these are gliomas of different grades. I think this is a glioblastoma, intrinsic tumor of the brain, and another glioma over here. A glioblastoma in the occipital lobe causing very few symptoms. And then quickly with the last few minutes, we'll look at some vascular abnormalities. So here's an MRV looking at the cerebral venous structures. Here's the superior sagittal sinus, the lateral sinuses, the transverse sinuses. You can see that in this case, there's some sigmoid sinus here, but there's a clot here. So bad-looking venous sinus. Here's another. This is an MRA or MRV as well. Here's the nice-looking nice-looking superior sagittal sinus. Here's the normal right transverse sinus and the narrowed and stenotic left transverse sinus. So when this occurs, the pressure goes up in the venous side, and then in turn the pressure goes up in the spinal fluid and can cause papilledema. This patient has a very large flow void in the cavernous sinus. This is a cavernous sinus aneurysm seen on MRI. So on MRI, flowing blood in this T2 weighted image, flowing blood is black. So this big flow void is an aneurysm. Here's the patient MRA, fairly old MRA. This is the carotid artery, the white, but this area here is the aneurysm. This is a patient with a cavernous sinus fistula. Here is this huge superior ophthalmic vein. Here's the normal size over here. So this patient has a cavernous sinus fistula where the blood flow in the venous side is under high pressure, and it's distended this vein, and the blood is actually flowing this direction as opposed to this direction back into the cavernous sinus. Here's another patient with a CAT scan that was read as normal. Here is the left side. You see the muscles are slightly enlarged, all of them, but look at the superior ophthalmic vein right here versus over here, this little dot. So this is a much enlarged, relatively enlarged superior ophthalmic vein, and this sometimes can be the only sign of a cavernous sinus fistula. It even can be seen on a CAT scan. So look for that on the coronal images, in particular on CT scans, if you have any level of suspicion for a cavernous sinus fistula. I think this is our last audience polling slide. This patient probably has which of the following? This is an MRA, double vision, bitemporal field defect, headache, or nystagmus. So the same choices as the last question, but different imaging, neuroimaging study done. Give you a few seconds to vote. And I got about a third of the people said double vision. About half said headache. That may be a, a lot of people get headaches kind of thing. Only a couple said nystagmus and a couple said bitemporal field defect. We can get rid of that polling there. So this is an MRA of the circle of Willis. So here's the posterior cerebral arteries. Here's the circle of Willis right here. And here is this posterior communicating artery, which is this artery and this artery. So this is a PCOM aneurysm causing a third nerve palsy. They may well have a headache, but for this purpose, I was looking for double vision because of their third nerve palsy. And some other findings, let's see. Oh, so this is a patient who had had an MR, who had had a homonymous hemianopsia, to try to just illustrate some different sequences. So here's a T2, right? See the white, the vitreous is white, the CSF is white, and you might say, well, there's something going on maybe back here. Not that obvious. Here's a contrast enhanced MRI T1, where now there's clearly something present going on right where you'd expect it, given this person, this is the left occipital lobe, so they have a right homonymous hemianopsia. But here's something called the diffusion weighted image. This is something that we do routinely now in the US. If they don't do it there, but you think there might be a stroke, an ischemic stroke, it's going to shine just bright white. So the best way to look for an acute ischemic stroke is DWI, or diffusion weighted imaging. And then finally, a few miscellaneous conditions. Here's one that I try to stump my residents with. This is a person who's got downbeat nystagmus. Downbeat nystagmus. And the brain structures look pretty good. Here's the normal pituitary gland. Here's the anterior visual system, optic nerve coming into chiasm. Brainstem looks pretty good, no obvious lesions. This is a T1, the CSF is dark. There's no contrast, but look down here. Here's the cerebellum, but look what's happened. That cerebellum is scooted down through the foramen magnum. This is a Chiari malformation, the most common cause of downbeat nystagmus. So Chiari, now not all Chiari malformations are symptomatic. In fact, most Chiari malformations, small ones, this is a big one, small ones are incidental and not relevant probably to the patient's symptoms. This is a CT scan, obviously. You see the nice bright white bone. This person has fibrous dysplasia. So here's the normal looking bone that's been remodeled and so on. Here's a patient with fibrous dysplasia, this abnormal bone deposition. And you can see what this has happened. Look at this, look at the volume, or I should say, I guess, the area of the posterior eye socket. How this is a nice normal looking volume or area. You can imagine that the volume of the eye socket is much smaller. So this person has exophthalmos and some motility deficits, possibly develop a compressive optic neuropathy. So fibrous dysplasia. Here's a patient that was sent to me with, they had a headache or something. They got the scan, and what did they say? Oh, there's something going on at the optic nerves. Right here and right here. Calcification. This is a person with typical optic nerve drusen. Optic nerve drusen. And then I think my last image is this, a patient with pain and loss of vision who has some enhancement of the optic nerve sheath, not as prominent over here, who had a condition called optic perineuritis. Perineuritis. No, actually, I take that back. I take that back totally. I think that this is probably just the normal nerve. What I see that isn't normal, and this is I'm sorry about that, is something else. And that is, look at this superior oblique muscle right here. Nice, normal, healthy looking. Look at this one. This is a person with a congenital fourth nerve palsy. And over the years and decades, there's just atrophy of the superior oblique muscle. So here's the muscle on the side of the superior oblique palsy, the congenital, and here's the normal muscle. Sorry, got that one wrong. So thank you for your attention. I think we have time, a few minutes at least, to try to answer any questions. The question has to do with dysthyroid optic neuropathy. So I think I've answered that question. If I didn't answer the question, because earlier there'd been a question about what do you prefer, I think CT, MRI. I think that the CT and dysthyroid optic neuropathy, I think, is superior because, again, it gives you that bone that you can't see on the MRI. And since dysthyroid optic neuropathy means usually there's going to be a tight orbital apex, well, how do you know it's tight if you can't see the bone? And on the MRI, you don't see the bone. I mean, you can get a feel for it, certainly. But the CAT scan is going to show you both the bone, the nerve, and the muscles. I hope that answers the second question, which was why is it better? What will be the best option to do imaging for tuberous sclerosis? So tuberous sclerosis, you're looking for tubers in the brain. So MRI of the brain with gadolinium would be the best study for that. Which one is superior in assessing transient visual loss, CTA or MRA? So I think that depends on what we talked about. It really depends on your center or where you're getting your imaging. If you have good CTA and good MRA, I don't think it probably matters that much. If you only have CTA or only MRA, then that's your choice. But I would ask your radiologist in that question, hey, we have both. Do you think one is superior superior to the other for this indication? I would ask them. It may vary from place to place. Hello, Francis. What reasons would determine whether we order T2 or T1 plus fat suppression plus contrast? So I think if you order an MRI, you're probably automatically, at minimum, you're going to get T2 and T1 images, automatically. If you order a brain MRI, you're automatically going to get T1 and T2. You're not going to get fat suppression, but if you really think the problem's in the brain, you probably don't need fat suppression. On the other hand, if you're not sure it's brain or orbit, then you want fat suppression, and you're going to have to ask for it. And then the contrast, I see films all the time that are done without contrast. And usually one of two things. One, it's normal, but you get the contrast and you find the answer. Or two, you find an answer, but then the radiologist says, oh, well, we could probably tell you better what this is if you give the contrast. So in the United States, at least, I almost always order it with contrast. Certainly if you're looking for something subtle or small, if you're looking anything inflammatory, if you think this could possibly be inflammation, you got to order it with contrast. If you think it's a big tumor somewhere, you can probably diagnose that without the contrast. But it's still, I think, I almost never order a scan without the contrast. Any role for x-rays and neuroimaging? Yeah. Well, of course, if you don't have a CAT scan and you don't have an MRI, then there's a role for x-ray. I think you're going to miss all sorts of things, of course. I think x-rays can probably still tell you if there's enlargement of the sella. So if you have a pituitary tumor, for instance, sometimes, not always, that tumor can enlarge the bony sella. Of course, with x-rays, you're going to just be seeing the bone, more or less. And so the indications, I mean, I have not ordered an x-ray in decades, personally. And I think if you don't have CT or MRI, you're in trouble from a neuro-ophthalmology standpoint, is all I can say. What is the role of x-rays? And I think we just talked about that. Can gray matter lesion in temporal lobe cause papilledema, or is it coincidence? The answer is no. The only way a gray matter lesion in the temporal lobe can cause papilledema is if it is huge and it is causing, increased volume in your brain, or somehow if it was obstructing CSF outflow, but temporal lobe lesions rarely do that. You'd have to have a big tumor. I can tell you, I just had a patient recently, my personal assistant of 25 years, who had headaches. I said, oh, let me look at those nerves, papilledema. And she had a big intrinsic brain tumor in her temporal, more than just her temporal lobe, that was so big it was causing papilledema. But a small temporal lobe lesion could not. If a pituitary adenoma, after orbital trauma, should we advise both CT and MRI of the orbit? I usually don't. Again, after orbital trauma, there's trauma to the orbit. I'm interested in the orbital structures. I'm interested in the bone. I'm going to order CAT scan. I don't order an MRI. If there's some finding, I don't know, well, let's just leave it there. I don't order an MRI if there's orbital trauma. If pituitary adenoma can cause unilateral optic neuropathy, how do we ensure we don't miss it if we routinely order MRI of the orbit? The reason you won't miss it is because when you order an MRI of the orbit, you are going to get the sellar area and you are going to get the brain. They won't just stop at the orbit. They can't, because when you look at axial cuts, it's possible they won't go really far back with the coronal images, but you'll find the tumor in the pituitary area. So you'll still get pituitary and sellar region if you order MRI of the orbits, or at least I do. But if you look at your next MRI of the orbit, make sure you see the sellar region, but I bet you will. Can 16-slice CT detect orbital and brain lesions in underbelly? Well, I mean, if the answer is sure, the wider the slice, in other words, the more millimeters between slices, obviously the more likely you might miss a very small lesion. You're not going to miss a big lesion, and you could find very small lesions, but there's a little more luck of the draw. Are you going to be within that? So when I showed you that image with the calcified optic disc drusen, I would never order a scan to look for drusen, because depending on the image slice, I could easily miss those drusen unless you're right on the money. And of course, it's way more expensive than ultrasonography or something like that. Is it appropriate to ask for imaging in all cases of third nerve palsy? So I think the answer in the general teaching is yes. I think recently it's become, we talk about the rule of the pupil and all that stuff. Bottom line is, for a comprehensive ophthalmologist, the safest thing is to probably get an MRI, if you can, MRI and MRA, or CT, CTA, in all cases of third nerve palsy. Now, do I order an MRI in every patient? Nope. I see lots of third nerve palsies, and if I see someone over the age of 50, with acute onset of basically a complete third nerve palsy with pupil sparing, I personally don't order an MRI, MRA, or CTA in that case. But I do order MRIs, MRAs, or CTAs otherwise. How can we exclude optic nerve avulsion? or traumatic optic nerve by CT only? Well, the answer is optic nerve avulsion. Certainly a CT would be just as good as an MRI to look for optic nerve avulsion. I don't think there's any difference between CT and MRI. For traumatic optic neuropathy, however, the CT or the MRI can be completely normal. So that would certainly not preclude. I mean, I'd say the majority of traumatic optic neuropathies I see, the imaging is normal. Now, there may be on CT, there may be a fracture in the optic canal that indicates to you, oh, there's been significant force applied. But I mean, most of my patients with traumatic optic neuropathy, I mean, they may have some broken bones in their face, which you're only going to see with the CT. But the traumatic optic neuropathy, clearly the nerve can look completely normal. Optic nerve avulsion, which I think is very rare, at least in my practice, relatively, optic nerve avulsion, extremely rare. I've seen a few in 30 years. A CT is going to show you the orbital optic nerve essentially as well as the MRI. What is your advice if the MRI is contraindicated? So that certainly happens to me quite a bit. They have a pacemaker, for instance, and they have metallic metal in them. So orthodontic metal braces, that is not a contraindication. And by the way, at least I have patients with orthodontic metal braces, and they just whip them off. I had a patient many years ago whose mother was an orthodontic technician, and she said, oh, we'll just take those braces off for the MRI, no big deal. So I definitely do that if the metal braces are going to cause artifact. At least in the US, I can't speak for where you are, the metal braces are not magnetic, however. So I clearly see people all the time who have braces who get MRIs with no ill effect, but certainly they can create a lot of artifact, and sometimes the metal braces come off. Clearly, though, people have other metal implants like the, as I mentioned, the pacemaker is probably the most common we see. And then you have to go with your next best imaging, which is going to be a CAT scan. Could orthodontic metal braces cause orbital pain and painful eye movements? No. In the case of cavernous sinus fistula after embolization, when would you prefer to reimaging study? What would you be looking for? The answer is, I wouldn't do a study at all. If you embolize a cavernous sinus fistula, now that said, if you embolize a cavernous sinus fistula successfully within hours or days, everything will get better. Their intraocular pressure will go down, the chemosis will go away, their conjunctival injection improve, their exophthalmos will resolve. I mean, it should happen pretty quickly, certainly within a week or two. They should be almost back to normal if it's successful embolization. So in that scenario, in my opinion, I wouldn't image them at all. Why bother? That said, the neuroradiologist might, the interventional neuroradiologist might well, or the neurosurgeon, that's fine. However, if their symptoms aren't going away because their intraocular pressure really should improve, I mean, within 24 to 48 hours or even 1 hour. It's almost immediate. If it doesn't, then you're going to have to reimage them, and you're going to use the same imaging modality that you diagnosed them, probably, hopefully, a CTA or an MRA to look to see what's going on. I think that is the end of the questions. What is the best, one more, what is the best type of MRI to diagnose upbeat nystagmus? So upbeat nystagmus is a pretty non-specific finding. It usually means, brainstem cerebellum, so an MRI with and without contrast of the brain, attention, brainstem, cerebellum is what I would say on the, I'd say nystagmus, attention, brainstem, cerebellum, MRI, brain with and without gadolinium. All right, so that I think is the last question. If so, thank you all for attending the Orbis webinar on neuroimaging. Please, I think they'll ask you for feedback. Please give me feedback. In the feedback, if you wish to recommend other neuro-ophthalmology, I guess, or other webinars entirely, I'm sure we'll be doing another neuro-ophthalmology webinar in the future. So please let us know, and have a good day or night, depending on where you live in the world. Thank you.